Thank you very much, Anita, and thank you very much for the invitation to do this talk. Although I think sometimes I almost invited myself up here, but so it's very nice to be welcomed in this way. The photograph here shows the main building at our university. They put all this pattern up on the building, so it's very easily recognizable. Sometimes people, they call it the cheese building or SpongeBob, but it's a very nice building, and the department that I'm from is fairly large because we're covering a wide number of areas within robotics, drones, and I'm in a little unit that is focusing on healthcare. What I would like to talk about today is mainly about participatory design ideas and methods, and I'll present to you some of the things that we did in a project, and you will be able to get new ideas, hopefully from what I say, but probably the methods are not directly transferable to this environment, but I hope that you'll get some ideas of what we do. I was asked to come up with a number of learning goals, and they are here. I think you can see them elsewhere as well. Denmark is a very small country. If you took it, you could put it in here and it will fit within the state with no problem. It's located at the top of Germany, beneath Sweden and Norway. And you can see it on the top picture, and the white spot up there is Greenland, and it's, by the way, it's not for sale. It belongs to the Danish kingdom, but there's not many people up there. But here's just some key figures for the Danish healthcare sector. There is a population of more than 5 million people. We spend about 9.8 of the GNP on healthcare. And it's all, or at least the very majority, is financed by public tax money. We have private GPs as gatekeepers for the healthcare system, so they very much decide who can get treatment and where. And they like to think of themselves as private, but 99% of them are on the contract with the public, so I don't know how private they are. They are paid fee for service. We have 22 hospitals in different locations, 13,000 beds, and they are almost all public. We have a small number of private hospitals, but they are mainly they are more like clinics than real hospitals. These hospitals, the public hospitals, they are owned and run by 5 regions in the country, and all the long-term care and home care and a lot of the preventive activities are taken care of by 98 municipalities. You see, if we look at the resources used, then you can see that it's a very small part of the population that actually use most of the resources. So for most of the population, the healthcare system is actually organized quite efficiently. They don't spend very much resources. It's the top part that spend a lot of resources. And I think this picture can be replicated by many other countries. And of course, it's not sustainable to have a healthcare system like this. So there's a lot of initiatives that are using technologies to do something about this situation. And the challenges for all these eHealth initiatives or health technology initiatives is that the technology is used very differently in different areas. It's very often criticized that it's not sufficiently supported or supporting the clinical work, and they also very often it's shown that when you introduce new technologies, it creates new problems. So there is a need for both to evaluate patient safety issues, usefulness, and so on before the technology is actually taken into use. But there is also a very big need for new ways to anticipate these issues before you can actually evaluate them. And this is the activity that I'm focusing on. And it takes very much the point of departure in human factors engineering. Here, it is a well-known fact that you cannot write all that you say, and you cannot say all that you know, and very often you don't know what you know until you actually need to know it. Sometimes you find out that you don't know right away, but you know how to find the person who does know. So you could see that the knowledge in our field, it arises primarily from interaction instead of evidence. I mean, imagine a clinician that has a specific problem. He doesn't know the correct dose for something. So instead of going to a computer and make a Medline search on it, he would rather call one of his colleagues. That is the way that this sector works. So we need methods to study interaction instead of just study how people work on books. But work practice in healthcare, it must be studied on 3 levels. First of all,
could you please speak closer to the microphone?
Sure. Okay. No, that's okay. But on the first level here, it can be done very much by doing interviews or talking to the patients, or by surveys. It's very often surveys that are used. But you also have to focus on what people they think they do. And that's usually different to what they say they do. But you can only get into that by very deep interview or observations. And observations is actually what you need to do in the 3rd level, where it's a question of what they actually do, because that's also sometimes different to what they think they do. So we have to do studies on these 3 levels, and it makes it very complex because the systems that we are talking about, they are working in a complex healthcare sector and from a human factors perspective. It is very complicated or complex. You very often see how people they talk about the work in healthcare as very complex, but sometimes it's not complex, it's just complicated. So I want to discuss these kind of these issues. And because in healthcare, the information technology is many things. If we look at the different systems that we are using, then they have different abbreviations and so on. And it seems very complex and very complicated, but maybe it's not completely. But let's have a look at it. If we look at it from a technology point of view and a requirements point of view, then the technology, for instance, can be the concept of technology can be close to certainty, or they can be far from certainty. If you look at the requirement, there can be consensus about it, they can be close to agreement, or they can be far from agreement. And then we can point at different, this model is taken from the literature. It has been used in so many different areas, but I try to use it in characterizing healthcare systems. So the problems and the approach to solve them can be simple, it can be complicated, it can be complex, or characterized by anarchy. So that is sort of the different phases, and there is a difference between the different concepts. Try to illustrate it with some other technologies. This is a key for a car, and it's fairly simple. You know, it has 4 buttons and you know what will happen if you push one of them. You might not know all of it, but to design such a thing is not a difficult task. Becomes more difficult if you look at the what it is used for. A car is a lot more difficult technology to see how it actually is working. And now I'll see if I can get the next one working. This is a lot more difficult when you put the cars into a context where it's actually used for some purpose. Then it suddenly becomes a lot more difficult to see what is actually happening. But it without describing the rules, it actually seems to work. And there is a difference to the next situation here. Oh, here. This is completely chaotic. Nobody can come anywhere. It just comes to a complete halt. So this is just to illustrate that there are differences in the different ways we look at technologies. We distinguish between the what is complicated and what is complex. That is, I think, quite important in our area. So if we take what is written here about the two concepts and look into the diagram and then add the different components that I just showed you, then the key to the car is fairly simple. The car itself is quite complicated because there are so many elements in it that you cannot immediately see how every element is going into it. But if you look at what happens if you put it into use, it becomes quite complex and very difficult to see what are the actual rules that is directing how people are doing. And the situation in I think it's from a market in Calcutta is complete anarchy. Nobody can move very much. But if we apply it to all the systems that I showed you before, there are some parts of healthcare technology that are quite simple. I won't say they are completely simple, but laboratory information system and patient administrative systems are quite simple in a way that they are built up. It's fairly stable information they are treating and so on. It's different to the EHR and telemedicine, and I just put genome medicine in there that is closer to anarchy. But it also means that we have to use different methods to study and to design these kind of systems. It's not the same approach to design a new patient administrative system as it is to design a new EHR system. But for most of them, it's characteristic that the innovation process, it's simple and it's complicated and it's complex and sometimes chaotic, but at the same time. So therefore, we need to use, or we have to use the adequate methods to each different type of project. I'm going to just characterize it from another point of view, from a sort of post-normal science view, where you have the system uncertainties at one dimension. It can be low or high. And you have the decisions that are at stake. They can be at low or high. And then in the inner end there, you can point at applied science as a way of approaching the problems. System uncertainties are low, and decision stakes are simple and small. And that's how you can apply science in a fairly simple way. If we go to the next level, then we talk about professional consultancy, and it's mainly because you have to add some judgment that are individual and based on expert knowledge. But the interesting thing is that if you go to the next level, we need to apply post-normal science in order to grasp system uncertainties on a high level and also decision stakes at a high level. But what is this? And that's what I want to characterize as participatory design. That's where it comes in, where you need to engage the participants as future users in order to solve these kind of problems. And we are all, it's a very positive word to involve the users. Who would argue that it's not necessary? Very few people would do that from a point of view. But sometimes it's overdone, and it's just illustrated by this one, that you have the best intentions, but maybe what you have decided to do does not work all the time. There are things that are not so good, and I especially like the woman that comes with the carrot for the giraffes. I don't know if giraffes like carrots, but there is. It's not always that the good things are resulting in good results. So if you look at what people they talk about when they talk about approaches to involvement, then we try to make a kind of a scale. Very often you talk about user-centered design, and it's very much applied science you use from the former diagram. And I've always had a little difficulty in understanding what user-centered design is, but because what are the users in the center of? It doesn't always make good sense to me. But to another degree of involvement, it could be something we call cooperative design. Here's that's where you apply professional consultancy. That's where you try to engage the users in a collaboration fashion, and you have to set up organizational frameworks for that. But the third one is what I have been more engaged in, and it's what we call user-driven design. We want the users to actually be the creative source of the design, but it's not so easy just to do it because they're not used to it and so on. It requires new techniques and new methods, and that's what we call post-normal science. I think this is just to illustrate that it's how important it is to choose the right tool for the right situation. I mean, you could imagine what the bottom picture is the Norwegian royal family. If you gave them a Swiss knife for their dinner, it wouldn't fit. I mean, the dinner would not be a success, and it would also be very difficult to have the chopsticks when you are sleeping in the woods and so on. So you have to find the adequate tool. But why should we then involve these users? There are a few arguments here that they are the ones who have the knowledge about the clinical content. They have the knowledge about how they work in the practice, and also we need to involve them more because the issues that we are looking for are not always visible. You have to use special techniques to make them visible. So there are a number of challenges, and this is what I'm going to show you from a project where we analyzed work practice in a cardiology department at this Copenhagen hospital, and the problem was from a European project perspective that medication errors, they happen very often, and sometimes they're serious, not always. And CPOE systems, they often diffuse very rapidly. They are used all over now, and very often they have decision support elements within the systems, and also that new types of errors they will occur. So we tried to, first of all, to identify the medication errors in the hospitals by data mining in patient records in both in Denmark and in France. We had several 100,000 of records that we analyzed and found patterns. And then we wanted to build and improve decision support for prescribing, dispensing, and administering medicine. Here you see just all the partners. There were many different European countries involved in it. But our task was to find out how is decisions actually made in a hospital during a medication process, both for prescribing and for dispensing medicine. So what we did in the beginning was to investigate this, was to do some interviews with a number of doctors and a number of nurses. And prior to the interview, we gave them disposable cameras. And there is a reason why we use disposable cameras, although you might think they're a bit outdated because everybody has a camera in their phone. But when you take a picture with a disposable camera, you cannot delete it. If you do that with your phone, you can always take another picture because you didn't like this one, or you can do this and this. But here you have to take new pictures every time, and it forced the users to be more spontaneous, or to at least to give us the results of their spontaneousness. So we just gave them and asked them to take pictures of important medication situations that they felt was important when they were handling medicine. Then we did an interview here with one of the nurses. We simply asked her to how she was performing dispensing, administration, and prescription. And we immediately, every time she mentioned an issue, we put it down on a board according to these four elements, which is from a technology theoretical point of view. but it had the very good implication that here you can see that every time she mentioned a thing, we wrote it on a sticker note and put it up on the board. And it was a way of interpreting the interview at the same time as doing the interview. Because normally when you do interviews, you record it, and then what is it called? You type it, and then you send it back to the one who you interviewed and said, was that what you said? And then you have validated it and so on. But here we actually do the interpretation of the interview with the users at the same time. And when she couldn't think of more elements in her work, then we took the pictures out and said, what did you photograph here? Why is this doing this here? And ask questions from the pictures. And it actually turned out that she was thinking of more elements that she just had from memory. And you can see we changed the color of the sticker notes after they got the pictures. So it really improved and it increased the number of issues. Then we saw that this was how we imagined the process of medication, and now we got really good information about how they did the dispensing process. But it also turned out that we found that the way they did it, when you asked them, was they sort of rewinded till when they attended nursing school, and then they told you how they were taught to dispense medicine. So we thought it could be interesting to see how they do it actually. So we did a video recording of their work in the medication room or the medicine room, and you'll see a small clip of that afterwards. And actually, we repeated the video several in other situations as well. For a full day, we had 3 cameras where we were following 2 doctors, 2 nurses, and we had 1 camera in the office area to get the more spontaneous work that was done there. And we were trying to find out how do they make decisions in their work. And it turned out to be very difficult to video film a decision, because you cannot see when people are making a decision within their head. There's only one situation where we saw it, and you'll see that in a moment. But we followed them for a full day. They start out by having a kind of a board round in the office where they use the blackboard and do priorities and so on. We see how they are discussing the prescriptions on the computer system. And they go to talk to the patient, and this is where we can see that a decision definitely is made, because you'll see the video in a minute that the physician hand over the paper with all his medicine, and then they're discussing a specific drug, whether we should change it or not, and then the physician actually decide, yeah, I'm going to change it. Then he takes the paper back from the patient. So that's really where a decision was made. They go back to the computer and have a second round where they use the CPUE system as a registration system. And then at last you'll see the dispensing situation. And now I'll see if I can get the movie to... While we were there, there was 2 patients that had a very low heart rhythm. So they monitored them very closely, and they were an audible alarm. And also, this is the door into the medication room. And it turned out that they put this bucket, you can see here, in the door, because normally it's locked. But in this situation, if one of these patients had a heart stop, then the nurse that were closest to the room had to go in and get some medication, the atropine for it, and then run to the bedroom where she was. And if she didn't have the key present, then it would take more seconds to open the door. So just because of relations to the patients, they put this bucket in the door so it didn't lock all the way up. But what was also quite funny, it just tells us that they are breaking the rules, breaking the way they should work, but always with a good reason. The next thing we saw was this cupboard. Okay, it's because it's behind here. I can't see the screen. But in this one, they had all the narcotic medicine. But also they were very rational. So to save money, they bought in big quantities. But sometimes the big quantities couldn't fit into the cupboard, so they just put it on top. And if you can see what this is, I mean, it's not quite safe to have the bucket in the door and this bottle on top of the in central Copenhagen, where there's a lot of people who would like to get hold of this bottle. But of course, it's a breaking of the rule, but they really had good arguments because they wanted to save money. So we were studying the medication process, and we had imagined that it was quite a linear process. First you do the prescription, then the dispensing, and then you administer it. But when you watch it, it's like everything is just mixed. You cannot distinguish the different phases so easily. And we also saw from the video that the different information obtained to make the decision is from a digital artifact, it's from papers, it's from a nurse, it's from the patients or other sources where they meet somebody at in the corridor or so. So it's a very complex picture of how decisions are actually made. We tried to make different scoring of the situations in the video, and we came up with these kind of flow diagrams and so on. It's very informative for a deep analysis to do it. We looked at how the different patients, they are the different colors, they what kind of information they used for the different kind of patients and so on, and came up with different kind of ways to illustrate it. But the results were that information are collected from many different sources, decisions are made in many different places. So it's very difficult to have decision support if it's only a computer. In this case, the CPUE system was used as a data entry system and not as a communication system. So what we did further on was to come up with a design game, because now we knew something about the problem, how they were working and so on. So the next step would be to see how should we then actually design a system that would help them make better decisions. And we took as inspiration to construct a design game. We used this one as an inspiration. I don't know if some of you know this computer game called The Incredible Machine. It's a playing field where you have different elements that you can draw into the field, and if you push the button in the top, then you add gravity, and everything that is hanging in the air will just fall down. So this ball up there will fall down, ignite the torchlight that will ignite the candle that will make the cannon go off, and the ball will go down there and trigger something else, and the paper will immediately disappear from, so the monkey can see the banana, and he will start to bike on the bike, and the cat will be sort of thrown off the conveyor belt. Something will happen if you trigger it. So we wanted to use this as a design game for some clinicians, for 2 nurses, and 2 doctors. We divided them into 2 teams, a blue team and a green team, and each team, they got a number of scenarios where the scenarios were extractions from a database where from adverse events. So they were truly things that had happened. It was not something that we designed. It was taken from reality. So nobody could come and say, this situation will never occur here. But it actually had occurred some places. So that was the description of their task. So they also got an empty machine, and they got some blank sheets and a number of predefined functionalities. And the predefined functionalities was following this scheme, which is an Australian way of characterizing decision support, where you on the first level just have the basic activities that are in a process where you want to make decisions. You have to collect some information that is whereupon you make your decisions. Then you can, with different computer programs, you can make trends and make graphics and so on. In the third phase, you have more advanced deductive inference engines to put in other information. And it's only on the fourth level where it make use of these more complicated statistics theories and AI and so on. But very often, if people they talk about decision support, they just on level 4 they imagine it. But all the other levels can be just as productive in the clinic. So we came up with a number of functionalities that we could think would be something that were in the machine. So each team they work at the same scenario, and the task was then to build a machine that could have prevented the ADE in the scenario. So what would it take to have prevented this? And then we had a game master that kept the time and a point master to keep the score. So we wanted to add a bit competition between the two. It's always stimulating for doing more activities. And here you see one of the teams working on building a machine, putting different functionalities into the machine. Here's the other team. And this is the result of different machines. And then we wanted to prioritize which machines are good, which are not so good. And then we gave them M&Ms. It looks, I mean, it sounds very simple, and it is, but it has a great effect to add M&Ms in a quite serious activity. They always start to discuss whether they like the yellow one better than the blue one and so on. So it eases up sort of the situation for the activity. And then it has another advantage because you can just take a picture and you'll get an immediate sort of impression of the results. Here's an example of a machine from the blue team. They wanted to add these elements, and they described what they actually wanted the elements to warn for. So on the basis of this, we made a mock-up with these different functionalities that they had made, and this is just made in Excel. It's just a matter of designing a screen. And then we had a workshop where we presented this screen for all the users again, and we cut it out, the small window elements, so they could move it around and so on. And we had really looked at the good advice from Donald Norman and Jakob Nielsen and so on. So we placed the information you need most in the middle. That was our thought, that this is the right way to do it, because that's how the theoretical approach would tackle it. But it turned out when they were working on it, they said that we want the decision support to appear in the middle of the screen. And the more important information that we also need, we'll find that because we know what we're looking for. And I think that's important to remember, that we are not, in this case, designing a data processing tool. I mean, we're not going to book a flight or buy a book at Amazon or so. But the clinicians, they are actually browsing for information to support their decisions. And that's not a data processing tool. So it turned out to be very important to confront the users again with what we had thought. And again, we were proven to not have the correct ideas. So this was the final result. That I'm not going to take you through that, but you can see that it was considerably different than the others. And this was then actually built as a prototype by IBM in Denmark. And afterwards, we tested that prototype in a simulation lab that we have in Denmark. It's on the 25th floor of one of the hospitals, and the whole floor is designed as all the other floors in the hospital. So there's a very true working environment, and it gives a very good way of testing because it's not a constructed test situation. It looks very real, and we had actors in the bed that were sort of playing patients. I think I will stop around here. Just point out that about something in participation. This is Arnstein, who wrote a paper in '69 about About participation, about citizen participation. It's from another point of view, but it's worth to note that people, they want change, but they hate being changed. So it's the way to go about change is to involve them. And then she made this ladder of different degrees of involvement. So there's from manipulation, which is absolutely the opposite, therapy, informing, consultation, and so on. And then she tried to divide it into different steps of where we are heading. So I think every project could try to place itself on such a ladder to see where are we? Are we high enough on the ladder, or can we do something to move even further up? And just to finish it off, we found this French student poster. So it's in French on one side, and you can see here, I participate, you participate, he, she participates, we participate, you participate, and they profit. Thanks.
Thank you. We have a maybe for questions. First, I want this to be an interactive session so that we have like 15 minutes to chat about topics.
Hi, my name is Alyssa Russ. I've very, very much enjoyed your talk. I'm a Human Factors faculty member at Purdue, so it's a delight to see some related work presented. I was curious about the study you did with the cameras and the video. One, that's a really neat approach. I don't know if I could get that approved here, but probably not. But I was wondering, as a next step, like, has your team thought about using cognitive task analysis or like a critical decision method to try to understand more the cognitive decision making, or wondered what your reactions were to that?
Yeah, thank you. It's about the video. We have done a lot of video projects in Denmark, and now we actually have quite some experience in it. And I think it is also very culture dependent. Some things are easier done in Denmark. We don't need that many ethical approval. In Denmark, we mainly need ethical approval if you involve biological material. Otherwise, you just need the consent of whoever will be in there. But it takes a lot of time to prepare it. We had several meetings with the ward there, and especially the head nurses, and we wanted to make sure that everybody knew that we were coming and knew what we were doing. So they had to put it on the board and put it on the staff meetings and so on to inform. And we also had small cards that explained why we were there, what we were doing in the pocket. So if anybody would ask us, then we could just give them some information about it. But our experience in these places where we've been is that they are actually very positive. And also we promised them two things. One was that they will get a version of the video that they could use for further education and staff meetings and so on. And the second was that we would not show it to somebody who will not understand it. So the reason why I can show it here is because you're all professionals. And please don't record it, or because the worst thing that could happen would be that it would end up on YouTube or something like that, because there is an interpretation to it, and I mean, the way I explain it has to follow it and so on. So we are very anxious to keep those two promises. But funny enough, to tell about the way it is received, then those that are, I mean, most people are concerned about the patients. What will happen if you video film a patient? But actually, our experience, it's quite the opposite, because we were filming in the office, and then a nurse came and said, now they're asking down in bedroom 5, when does the video team come? I mean, the patients, they are so eager to be on the video because it's very boring to be in a hospital. I mean, So nothing happens there. So if somebody is making an interview with them, they are very interested in participating. That's our experience. We've never met any patients that didn't want to appear on the video. And we have considered some other analytical approaches, but I don't have sort of a systematic overview of what we do. I think the main thing that we are focused on is to do very fast analysis of the video afterwards, because 3 video cameras for a full working day is close to 30 hours of video. So it's an enormous amount of data. So what we do afterwards is that we have debriefing meetings where we say something interesting was happening there and there and there, and then we focus on that. Titus?
So it looks like you got the users engaged quite a bit. I couldn't tell whether they were having any fun, but M&Ms may have done that. Did you make them happy afterwards? Did you give them a system that actually reflected the things that they came up with in practice?
That's very much the problems in doing projects that are, especially those who are European or financed by the European Union, because it's difficult to get something usable that will actually be applied by the vendors who has delivered the EHR systems at all the hospitals. And so I think we came up with a good solution in Denmark, but then the vendor focused on another market, and as you know, Copenhagen area has now implemented Epic, and I think it will be very difficult to get that kind of things into that system. But in France, they actually they built products that are used, and they're still used today. So they had a better success on going the full way into usable products that are implemented and used here years after.
I would posit that unless we solve that problem, you know, lots of good work in informatics will continue to go unused, you know. And I know Epic is run with a particular philosophy, and, you know, it's their company. Other companies strike me as somewhat more open to that kind of stuff, and you allude to the French example, but unless we solve that problem at large, we'll always have systems that don't reflect people's work practice very well.
Right.
Well, maybe to pick up on this line of thinking, and so the question I have is related more to inference than method, but you know, clearly you had a very international consortium of different countries, and you made the observation that in one setting they observed, wow, the senior doctors actually see the patients, so a very different context. So to what extent do you think that it's necessary to tailor these decision support tools to a cultural context?
I think it is very important. I mean, and we haven't, in all the projects we've done something different, because in order to motivate the users and the participants, you need to have something that they also feel is tailored to them. If you just want to apply some standard things that you have done many times, they don't feel that they should. Why should they engage in that? So I think it's very important to tailor it to the specific context all the time. And also another concern that has been raised very often is that it takes such a long time to involve the patient or involve the users. But especially in this project, it was our impression and our knowledge actually that it does not take very long time for the clinicians to be involved, but it takes a very long time to prepare it for us as a project. And especially when you observe the working environment and so on, it should absolutely not take extra time, because you sort of require everybody to do what they normally do. Otherwise, you won't get the correct observation. For instance, the design game we had, it was done in 1 hour. So the clinicians, they spent 1 hour in the project. We might have spent a week to prepare all the different stuff, but they spent 1 hour. And the same with the simulation afterwards when they tested the system. They were working in the hospitals. They just came up, did the simulation, and went back to work. So it was very, very few hours that the clinicians actually spent in participating in the project. But they only spent a little time if it's very prepared. So it has to be very, very well planned and prepared.
Yeah, I agree with you about the planning and preparation, because that case situation is absolutely crucial to make sure that people participate, showing their real abilities and customs and what is it that they do in real practice. About 10 years ago, I did a study very much like this, but I was not so much concerned on the issues of usability of patents, but actually on clinical decision-making with dentists. And at the time, we used a standardized patient. So it was not a fake patient from the clinical perspective, but there was one patient to be examined by dental students and by dentists. I know that you have a multi-site type of study, but do you see any obvious advantages in using a standardized patient, one case, that will remove variability or changes that are specific to the case, and just use one patient and then observe what the clinicians are doing?
What do you mean by one patient? Where in the process do you think of one patient?
Honestly, to use an actor with a specific set of clinical characteristics, but that person has been trained to present himself or herself in a certain light. So the social history is standardized, the clinical presentations are the same. They actually have the clinical issues, but you use one participant to be seen by different teams, and that removes the variability across different patients.
Yeah, I don't think I mean, we had 5 patients because we had 5 different scenarios, and it was more to, yeah, I think we had the users, the physicians, they used the system on different patients just to have them use it several times. But it was very quick to do it, and they sort of in simulation we learned that they very, very quickly forget that it's just a simulation. We had one of the senior physicians at that hospital. He was attending one of the patients that had some kind of heart problem, and all the junior doctors, the first thing they did was to go to the computer and look at his ECG. But this older physician, he wanted to feel his pulse. So he went to the actor and felt his pulse, and then he said, "Oh, this is really good now." And he completely forgot that it was an actor. It wasn't the patient. So I think to create this kind of reality, the hi-fi issue is important to have more cases and to make it more realistic to their everyday activities.
So it seems that the end goal there was mostly the product of the game in the end, to inform user interface improvements and how decision support is delivered. But in the way to get there, you found interesting things, side effects like the bucket in the door, etc. How do you use that information also when you report out, and because maybe some of those artifacts could also be part of the problem that you're trying to solve, but they will not inform the user interface in any way or form, but they may be interesting assets in the solution. So how do you make sure that you don't lose the material that you get? Because if I understood correctly, there will be a report in the end that will go to inform UI development, etc. But those guys don't understand about the routine of nurses and pharmacists, etc. They don't care about that. So, but you found interesting things there. Tell me, how can that also not be lost in the process?
I think there are two things in it. The things with the bucket and so on was just to underline that the rules and the normal patterns, they are broken, but for good reasons. There was always they're acting very rational. They didn't do it to harm anybody. They did it because they knew, they had the experience that they could save lives by having faster access. So that was just to inform the further process that you should not build systems on the rules because they are flexible, they are broken. So you have to take notion of that. The other thing is that we actually, because IBM was included in the project, we did we went to a meeting at IBM in Copenhagen and showed them some of the video, and it was very sort of surprising to us to see that all the programmers, they were there in a meeting like this. They had never seen how the system that they had programmed actually was used. So when one of the users were trying to find a specific thing in the screen, one of the programmers, he said that, why don't you just push the button up there? I spent 2 weeks programming that function and you don't use it. So, I mean, they'd never seen how their product was actually used in the real life. So I think that also tells something about how it can be productive to use the video to show to the programmers. I mean, we were quite surprised that the programmers had never been to the hospital. They never seen their product used by real clinicians. They just made sure that it lived up to the system requirements.
So I just want to thank you, Dr. Nøhr, for his very interesting and informative discussion with us today. I want to also let everybody know that Dr. Nøhr will be also presenting at the School of Informatics and Computing this afternoon at 1 p.m. And the talk of his talk will be user-driven development of IT support to everyday life with diabetes. Thank you, Christian.
Thanks.